it might be quite a non-specific appearance. And it was sent for, there must have been a suspicion because it was sent for screening for BRAF mutation by this mass spec-based screening tool that had been developed for melanoma, and that was reported as negative. So at the time, this is just also for interest that reflects many patients' journeys. She was referred to one of my colleagues. It came into the sort of general hematology inbox, and my colleague said, "Thanks for your letter regarding this lady. I note she's had a mild ESR, CRP, and inflammatory eye disease. You've excluded lymphoma. I do not feel as hematologists we have anything to offer here, blah, blah, blah," you know, and I haven't even sent her an appointment. And I think I think it might have been the pathologist actually phoned me up and said, "No, I think you really need to see this person because there might be a histiocytosis going on." But he's a very experienced and great colleague, but there's obviously, he was one of the older generation that didn't really see histiocytosis, so still some work to do there. So I did a PET CT, and the PET CT was pretty negative, really. So skeleton was pretty quiet. There's this little bobble here, which we'll come back to at the end. But it was confounded a bit by the fact that she was on steroids at that point from ophthalmology, and she probably had a slightly high glucose at the time. So, oh, you can see, just rotating that, you can see the inflammation behind the eyes. There we go, same image again. So I guess this is the first question, is what do we call this? Is this ECD, or is this just some orbital xanthogranuloma? And you're going to greet me with complete silence, I know. What do people think? This is TAX, the classification group. It's bilateral, I suppose, yeah.
What did you say about the pituitary again?
So there was some hint that the stalk was thickened, but she had no endocrine abnormalities. Right. So yeah. Sorry, I jumped in. This is I looked this up. This is so there is a classification of the 4 types of orbital xanthogranulomas, which, yeah, this is some Dutch study. I think Astrid was involved. But so they recognized adult onset xanthogranuloma, APOX, necrobiotic xanthogranuloma, and ECD as a cause of a retro-orbital xanthogranuloma, with this kind of, there's immune dysfunction in these 2, but no internal organ involvement, whereas if you'd find that, you would say, this is definitely ECD. Some differences in the pathology, and then this is Astrid's paper where if you find mutations, then maybe it's more likely it's in ECD.
By the current sort of
yeah.
Yeah,
exactly. Yeah.
I don't want to beat a dead horse, but it would not fit ECD by some metrics if we go by the existing definition.
Okay.
It's in the eye of the beholder.
Okay.
Who sees the patient, I think.
Cool. So anyway, it looked like it was just behind the eyes at this point. Okay. So what about this feature? So the absent pulse in the left arm. So I did an MRA, and I think over the years, as we've followed this, it's become completely occluded, and she has had some pain in her arm, but she's been, the vascular surgeons have said, we don't think there's a subclavian steel or anything like that. It's just, so would this make you think it was ECD? I'm looking at you because you published a paper on this.
Oh, you're going to, I think ECD is, it's a broader disease.
Yeah. Okay.
Unless you have right atrial.
So the retro-orbital granuloma and now occluded major artery. Still not ECD.
Again, I'm being devil's advocate. This is not what I believe in.
Okay.
But it's really, you right atrial tumors,
But Matt, the narrowing aside, was there anything outside the vessel? I mean,
So, not a very. They didn't comment very much because they will focus on it. But so when you look at the cross section of the CT, say, component of the PET, there's not a huge adventitial thickening. So it's a very short segment.
I think if there were something and then the pituitary were positive, then maybe you could convince more people. If it wasn't just the orbit, there was the pituitary stalk, and there was what did you say, Gaurav?
I think it still doesn't meet those 4 criteria that people have agreed on.
Remind us of the 4 criteria.
We started with knees, then we
Okay.
expanded it to hairy kidney, right atrial pseudotumor.
Okay.
I think the posterior fossa, unless I'm missing one other manifestation. Sorry.
Okay. So anyway, I did this a while ago on the plane. I can't remember what's coming next. So okay, here we go. Okay, so this is Gaurav's paper, which says that subclavian. You're on it somewhere, aren't you? Your patients. Anyway, so stenosis or occlusion of the subclavians is a feature of some patients with ECD. I was surprised how common it was. And this is you had this picture where there's obvious adventitial thickening around the origin of the great arteries, and that's responsible. But I think when you look at the MRA, it can be quite a short, like sharp occlusion. So anyway, that's that part. And then also Gaurav modeled for this paper that you published, I think. It was some people.
When I was younger.
Yeah. Okay.
I don't want this to be recorded.
So I mean, some people would do anything to get the Mark Heaney Award, eh? So, and that was the summary. So lots of, not necessarily diffuse atherosclerosis, but quite short stenosis. Anyway, so there is data on this. Okay, so how about treatment options at this point then? So the patient the eyes were quite well controlled on steroids, but with type 2 diabetes, obviously that was not sustainable. I referred her to vascular surgery. They said it's fine, just nothing to do. There didn't seem to be any other high-risk features of disease, and she was working full-time, but she needed to get off steroids. So what would you do?
Do NGS. Did we talk about it, or did I miss?
2018. So
Come on.
Come on. This is.
At least BRAF.
Well, there was BRAF.
Oh yeah, BRAF V600 was negative.
Yeah. Would that make you think it was ECD? If it's, yeah, okay, so mutation.
No, just for treatment options. I mean, if it's systemic xanthogranuloma infiltration, I would think of it the same way.
Okay. So those what I thought were my options at the time. So she could have a bit of interferon, assuming it was ECD-like. She could have some methotrexate. She could have trametinib, maybe. Any thoughts on that? No, okay, we'll keep going. So this is what happened then. So,
I mean, I just think those are all very reasonable. I feel like I've seen many patients who got the steroids to methotrexate for just this.
Yeah.
And I think they end up with me because it didn't work, but I think that it's probably done for a reason. I think that has worked for many people.
Okay.
I just haven't seen.
Cool.
Yeah.
Thanks. So, we fast forward a couple of years now. So I tried her on interferon, and actually, my experience, people tolerate interferon quite well. She's probably the worst at tolerating it. She got dizzy, she got palpitations. She had cardiac imaging at the start as well, and that was all normal, but that precipitated quite a lot of anxiety. And then her hair started to fall out, so we stopped the interferon. And then we went on to methotrexate. And actually, she did pretty well with this. She managed it orally. She got up to 20 or 30 milligrams. She was a bit tired, but she was already kind of a bit tired. So she went on with that. And she did have a response. So this was the PET scan that was quite quiet, this one here, 2018. And so these were kind of relatively brighter. So the SUV max was 5.7, 7.2, and it decreased, even though it looks brighter on this image. And the lesions got a bit smaller. And cosmetically, her eyes were fine. She had no diplopia. So it was kind of a clinical response. I think I slightly misled you, maybe on purpose. So at the bottom of this PET scan, it looks negative on the MIP, but when you look at the images on the co-registered images, you can see this tiny bit of sclerosis. And the radiologist said, oh, there's maybe a bit of sclerosis, but it's not lighting up. So there was maybe a trace of bone disease at the beginning. You can't really see it there. And that hadn't significantly increased. It was roughly the same. So I would say a partial response to treatment or a mixed response to treatment. So not too bad. So the next thing that happened was she got a bit fed up with this. And we were allowed to have trametinib. Novartis had a patient access scheme open in the UK. And they told us at the end of 22 they were going to stop the patient access scheme. So, and they said, don't rush to put all your patients on inhibitors. We're going to close it. And of course, we rushed and we put all our patients on inhibitors before they closed the scheme. So she went on trametinib at this point here, having had a good go with these two conventional therapies and a partial response. So we thought, okay, let's try trametinib, see what happens. So she went on that. But this was a nightmare, honestly. It was far worse than methotrexate. She had lots of tummy pain, vomiting. She had muscle weakness with raised CK. One time she came in, she's a bit she doesn't get too concerned with her health, but she came in almost unable to walk once. And, I was very concerned that it was the trametinib. Lots of joint pain. She was diagnosed with a peripheral neuropathy at some point, which may have been related to the diabetes. And then she got a really nasty skin rash with it, which I think is on the next slide. This sort of neutrophilic dermatosis that was very itchy and painful. This is the CK that was up and down. And this is copied from my sort of clinic letter, or the sort of on and off treatment, trying to juggle everything. So it wasn't an easy ride. And it didn't really work either, probably because I wasn't able to get a decent dose. So this was the initial MRI, and this was the 24 MRI when she'd had a year of trametinib. So she still has this infiltration behind the eyes. So I think in net terms, methotrexate, trametinib probably wasn't too much different. So what next? So we had a patient there's no more conventional options. She's not really responded to trametinib. Okay.
Can we please?
NGS. So this point, we had ddPCR, right? So we did ddPCR on all our historic biopsies. And at 5%, this would sometimes come under the NGS radar. But the ddPCR found a BRAF mutation. So that was kind of pleasing, gave us a few more options. So that's what we did next. That was 2 months ago. We put some dabrafenib in. And so they're a bit slow to report scans in the NHS sometimes. So this scan is still unreported, but to me, it looks better. So I think finally she's achieved a complete response to the dual therapy. And I sent her a message. She's away on holiday at the moment. She said, yeah, I'm fine. Tablets aren't too bad. So she's good, I think. So this isn't quite the end of the story. So the PET scan originally had this little thing, and they said, is this a lymph node in the neck? This little brightness is associated with I think the left carotid, and it's grown over the years. I haven't rescanned it since starting the dabrafenib, but she had several MRIs on it, and the radiologists have said this is we thought it was a glomus tumor initially. Yeah. Then they said, we think it's a schwannoma. So hands up for a separate diagnosis or ECD. Is this part of the ECD, the schwannoma, do we think? Or do we think it's You don't think it's part of the ECD?
We have seen lately a couple of cases, and I don't know if this is that bizarre of a case, but it could be a second cancer.
Yeah.
Associated.
Right. Oh, okay.
That's what your slide.
So this is my concern, you know. So I had a 30-year-old patient who had a cyst growing in the kidneys. She was from another hospital, and the doctors there were saying, "Oh, this is probably part of the LCH that she's got." And I'm like, "I don't think it is. I think you probably need to biopsy it." And she ended up having renal cell carcinoma. So I've always been very vigilant if there's another lump or bump. So that's the reason maybe to consider a biopsy, because there could be another cancer. On the other hand, I suppose I could just repeat the PET, and if it responds to BRAF inhibition as well.
So this was not after, oh, you just started her.
Yeah, I just started, yeah. So, and there are 2 case reports of schwannomas turning out to be Erdheim-Chester disease. So could still be part of the illness. That's it. That's my mystery case.